Okay, all, I'm Sarah Massoud, and I have the pleasure of introducing our panel today. So a little background on our study. In 2018, under the leadership of Carol White, we were awarded an engagement award by the Patient-Centered Outcomes Research Institute, or PCORI, and you heard from Rachel a bit earlier today about PCORI and some of the other projects they have going on. So our project involved the establishment of a diverse group of stakeholders in dementia care research. And we use the word stakeholders simply to mean anyone with a vested interest in research related to dementia care. So the goals of this presentation. So our stakeholders on the council represent wider community groups, including people living with dementia, family care partners, geriatric and palliative care providers, and representatives of various community organizations in dementia and caregiving services. So over the last 20 or so months, our Stakeholder Advisory Council has worked together and with the community to generate a long list of research topics that are important to them. So some of you may have recently completed a survey to help our advisory council prioritize that long list of research topics to represent what our stakeholders feel is most important to have studied in dementia care research. So if you're attending today and you haven't completed the survey yet, look out for an invitation from us after the symposium. We'd love to get your input on that survey. So to keep things brief, I'm going to get right to brief introductions of our speakers, but they'll tell you a little more about themselves. So you'll hear from 4 members of the council speak briefly about why they're committed to participating on the Stakeholder Advisory Council, and they'll offer some examples of research topics included on that long list that resonate with their interests. So Ginny Funk will lead the panel as a representative of the Alzheimer's Association. And then we'll be followed by Kiki and Michael Foster, who are an incredibly proactive and motivated family living with dementia. And then we'll hear from Angelica Davila, an experienced clinician at UT Health Geriatrics and Supportive Care Clinic. And then lastly, we'll hear from James Butler, a chaplain in hospice care, an author, and a dedicated advisory council member. So Ginny, I'll let you get started. And what I'll do is I'll deactivate my camera. And once I reactivate, you'll know it's about the 6-minute mark. And if we hit 7 minutes, I will unmute and try to politely interrupt.
Okay.
Okay. All right. Thank you so much.
Sounds good. Thank you so much, Sarah. You know I can talk and talk, so I'm going to talk fast. So good afternoon. I'm Ginny Funk. I'm with the Alzheimer's Association, and I just want to say hats off to Sarah and Dr. White and everyone who has been involved in putting together today's program. It's just been phenomenal. I think every presenter, including Dr. Hummel, I've just learned so much. I feel like this is something that not only the people who are participants, but I'm so glad you are recording this because I hope that we can share this with so many more people. So yes, I'm representing the Alzheimer's Association. We are so grateful to have been invited since this began, and have participated and just tried to absolutely bring together and represent all of the families and individuals living with dementia that we work with. I also have my own personal connection to dementia with having lost my mother, and I just feel like, gosh, there are so many things that I would redo if I could, but certainly I absolutely love what Dr. Hummel said repeatedly. Don't talk about us without us. And when my mom was in long-term care, I used to think about that there was so much talking over that was being done when she was still more than capable of being able to answer and respond. So anyway, we, again, I want to say I'm in daily contact with families right now who are not only going through this in a very stressful time, but adding COVID to dementia has just been, it's been really difficult. And so everything that we can possibly do to provide support and to work together. I also absolutely loved the slide that Dr. Hummel had about partnerships, collaborations. if you all have had a chance to look at the chat, there are so many resources available. It's just incredible. So we just absolutely want to make sure that people know that they're not alone. And so on the next slide, I just want to kind of quickly highlight 3 of the questions that we feel like were of particular importance. And so first one in the category of diagnosis, really looking at asking the question, how important do we need to be looking at this and researching this? How to manage anxiety, fear, and other emotions related to a diagnosis of dementia. Some of these things have been highlighted prior today on just the emotional impact of receiving the diagnosis and where do you go rather than just being sent out of a doctor's office and feeling, I just can't even imagine. So again, very important for us to make sure that we are hearing from individuals themselves on the support that they need from receiving the diagnosis. Another one from that category of diagnosis, how to improve the process for a more timely and accurate diagnosis of dementia. And I know we've heard about research several times today. One of the, I would say, foremost priorities is the diagnosis of dementia and how that is, we still have a long way to go. It is, as you all, many of you I'm sure know, it is extremely difficult to get a diagnosis. There's still not just that one simple way. So this is definitely an area that just needs even more research. And then in dementia research, understanding ways to enable people living with dementia and their care partners and families to actively engage in research. And that's something that I feel like has been repeatedly put in the chat. So I hope that you will please check those links out. Of course, I'm representing the Alzheimer's Association's Trial Match, which is a free clinical studies. It's a matching service that connects people with all kinds of different dementias, their caregivers, and then what we call healthy volunteers, people who do not have dementia, connects them with current research studies. And there are drug and non-drug studies being conducted at sites all across the country and online. I can remember when my little trial match went bing, and I was able to participate in a study, but it was online. I didn't even have to leave my office. So again, I just want to say thank you so much for everything that everyone has contributed today. I've learned so much, and I just really appreciate the fact that we're very blessed in our community to be able to partner together with all of the stakeholders who are involved in this advisory council, and we really share resources. Again, our whole goal is just to try to reach more families and individuals with dementia to be able to provide support. So can't believe I haven't gone over time. So I'm going to shush and I'll turn it back to you, Sarah.
Thank you so much, Ginny. That was wonderful. Perfect. So I would like to invite, if it'll go, Kiki and Mike, if you want to unmute. I'll do the same thing at about 6 minutes. I'll turn my camera on just to signal that you're approaching the 7-minute mark.
Sounds like a plan.
Sounds good to me.
Okay. Michael and I are going to share with you his diagnosis with dementia, a very short story. The symptoms of cognitive impairment may show up slowly before the diagnosis is given, in lots of different ways other than forgetting where you put your keys or forgetting what your college roommate's name was.
One of the symptoms is very interesting for me. I had trouble seeing, and we call this, it all started with a bottle of wine, because I'd gone out to pick up some wine for dinner. Walked into a store that had a sale going on, saw some wine I liked, and it was at a great sale. So I grabbed 2 bottles. It was $7.35 a bottle. And went up to the cash register and gave the lady $20 bill, and she says, excuse me, but your bill is $35. So I gave her another 20, got the change. And then I went back to check how I had missed something that bad. And sure enough, there on the stand, big as life and twice as ugly, it was $17.35 a bottle. Obviously, I had missed the one. So I thought, well, Mike, you probably need new glasses.
And the doctor did a thorough eye examination. He looked deep into your eyes. And after his examination, he said,
go to your primary care doctor and get an MRI.
And we did. And a few days later, the MRI showed a diagnosis
of Lewy body B. And it's, you know, what Lewy body B is what Lewy body B is. But
so there it was.
Yeah. So I had dementia.
It was official. So what does having dementia mean to you, Michael?
Well, I said, okay, you know, I can sit there and say, I've got dementia now and can't do anything else. And I said, no, not to that. I can do a lot of things. And I said, I'm not going to let it get me down. So we went through with various things to see what we could do. And I'm not ashamed of having the disease. I'll do everything I can to help anybody else that has the disease. And interestingly enough, one of the first things that we did was get a hold of the lady at church who puts out our bulletin. And she typed it up, and we gave her the whole story. And it went out that week to all the members of our church. And the story was it all started with a bottle of wine, and it has nothing to do with drinking. It has to do with the fact I couldn't see. So when we went through with the different exams and tried to straighten things out, it was really, really interesting. But I'm here. No, I do not drive anymore, so nobody has to go out there and panic. It is a pain sometimes. I forget a lot. But that's neither here nor there. I've always forgotten things.
But you've gotten a good start.
Oh, yes. Well, I'd like to tell you about a friend of mine by the name of Janet. She taught me something, and it's what I believe right now. I have dementia. Dementia does not have me.
That's a good start, Garner.
Thank you.
Okay. What I'm going to share with Michael on this stakeholder presentation are effective approaches other than medication to manage behavioral symptoms. Number one, speak honestly and have an open communication. We have found that that's the most effective tool to help mitigate the behavioral symptoms that tend to pop up. And number two, avoid asking people living with dementia to make a decision. Ask them rather to make a choice. 3, try to eliminate clutter from your environment, especially in the areas used frequently by those who are living with dementia. Keep counters free from stuff. Tables, chairs, couches, shelves should all be decluttered. And use music as a method to decompress, calm everyone, and enjoy life. Place a day 2 calendar in plain view for the household to see, preferably on the wall, but only have 2 days on it. What's going to happen today and what's going to happen tomorrow. But above all, make laughter a part of your vocabulary. Yes. Anxiety and agitation can be exacerbated by moving into a new residence. You need to involve your loved one as much as possible, as much as they're willing to be involved in the move. Travel, even for the best reason, can sometimes cause some stress. Hallucination can be dealt with, but must be dealt with truthfully. Never tell them what they are reading is not true. And lastly and quickly, please take advantage of making advanced care plans early in the diagnosis. Today, Medicare will pay for the diagnosis whether you have dementia or not. It's all part of your annual wellness survey. And it's very important to lay down the plans as to what you want and what your family understands that you want, rather than having them make that horrible decision and have that horrible talk when you are no longer able to speak. Thank you, and keep living life.
That was,
Thank you.
thank you so much, Michael and Kiki. That was absolutely wonderful. I'm going to invite Dr. Angelica Davila. Oh, hi, there you are. So I'll disable my camera, and when you're approaching the 6-minute-ish mark, I'll turn my camera on.
Perfect. All right, welcome everybody, and thank you all for joining us. I'm Dr. Angelica Davila. I'm a family medicine physician. I did extra training to take care of older adults like Mr. and Mrs. Foster, and I'm also a hospice and palliative care physician. Our clinic here at UT, Geriatrics and Supportive Care, we're actually very unique. We not only take care of patients here in the clinic, but we also take care of patients outside of our clinic and in the community. So you will see that it says acute, which means hospital. We actually rotate at a local hospital here. Post-acute means rehab, so we take care of our patients when they go to rehab, certain locations. Long-term care, which may be nursing homes, and hospice. We're actually directors of hospices as well. I did all my training here in San Antonio. I'm born and raised and wanted to stay here in my community, and so did my training and now practicing here in San Antonio. This Stakeholder Advisory Council is very important to me because for me, I need to learn from our patients and their families on how to better take care of them. We learn a lot in medical school, but book smarts and what people are actually experiencing in their lives are very different. And so it really is upon us to continue to learn from our families, our patients, and colleagues. So I love this community because we are learning from people of different backgrounds, of different disciplines, and it helps us put that all together to really care for our patients. Can we go to the next slide? Thank you. So the topics that are important for me, it's always interesting to know if the information I'm giving to a family and my patient is actually helpful and resourceful. So if I could get feedback on the information we're giving, the resources we're giving, and if that actually helped them, that would then help me focus on those resources for other patients and families in the similar situation. I think it's also very important because many physicians will let you know that knowing resources and information it's not taught to us in medical school, and it has to be a lot of outside and connections that we make with people. So having that information and being able to share that with other clinicians would be really helpful for families. And here at UT, we do a lot of teaching to the younger generations, right? So our nurses, nurse practitioners, our physicians, really training them to understand the information and the resources that would be most helpful for families when we're giving a diagnosis of dementia. Another question that's actually in this research was information and resources based on the stage that you were diagnosed. And again, that is very different. We have our primarily older adults, maybe over 80, that come in and we're giving a diagnosis. But we do have young patients in their 60s coming in, and those conversations and those resources may be different for them. So information and resources is always, I want to know which ones are actually helpful for families, and that would, in my mind, help me treat people better. The next question that I think is really important is understanding how trust with your healthcare provider affects health outcomes. In our clinic, we actually offer 2 different types of appointments. We offer primary care, which means we are here seeing the patient repeatedly and building relationships with them and their families. But we are consultants as well. They may have a primary care doctor on the outside, and they are just coming to us for an evaluation of their memory and possibly dementia. So it's always curious to me whether the relationship that we already have with the families, if that eases the diagnosis. In theory, does it help at all? So I think it'd be very interesting to kind of gauge how people partake the diagnosis coming from maybe their primary care physician, or maybe a physician that they just met that day. So learning about trust and how that could help is really important for me. The third question, identify how to support people living with dementia and their families who are vulnerable and at high risk for poor health outcomes. So I was born and raised and grew up on the south side of San Antonio. My heart is still very in the south side in our underrepresented groups. And here at UT, we're actually part of a grant that's working in lower income areas, and we are continuing to do home visits in lower income areas. So I think it really is important to understand whether socioeconomic status, your financial status, if that affects how we are providing care to you, if we have to do things differently, if resources are different. So what could we continue to do to support our patients who are definitely are more vulnerable in those terms? That's all I've got.
Thank you so much, and perfect timing too.
Oh, perfect.
That was really well said. Thank you so much, Dr. Davila.
Thank you.
So, I'd like to invite our next panelist, James, to activate your camera. Are you able to? And
I am able to. Thank you so much.
And you're outside. Okay, so I don't know if you can see me, James, but I'll try to interrupt around the 7-minute mark, okay?
I will not be offended when you have to interrupt me. Yes, I can see you. Good afternoon, everybody. An excellent presentation to all who have come forth. Again, my name is James Butler. I am a chaplain with Heart of Texas Hospice. I'm a proud partner with our Stakeholder Council at UT Health Science Center, researchers to support caregivers for dementia. And I'm a husband, a father, a grandfather, and I'm outside. I'm not at the beach. I'm in my neighborhood because something happened with my internet, but no excuses. If you all don't mind, I don't mind getting started, if you will, please. I want to share this with each one of you all, if you don't mind. There's a question, a few questions we want to point out today. How to support accepting the diagnosis of dementia for people that's living with dementia and the families who may be in denial, That's the key. Well, first of all, this is one thing we want to do. We cannot start over at that moment that they received the diagnosis. We can't go back to that moment, but we can retrace the steps. That's very important. And why do we want to do that? Number one, because they didn't quite catch everything that was said in that moment because they were in a shock. So what we want to do is present a ABC approach. Number one, assess and process. We want to revisit what was told at that moment because the news that was just brought to them was the first time that they heard it, but they didn't exactly hear it. It was too new, it was too shocking, it was too confusing, it was too painful. So let's assess, that's A. B, breathe. We want to give them a fair opportunity to breathe or breathe again because people have the tendency to become very anxious when they hear the word dementia. People don't even say it. they whisper it as if it's tagged with something that means trouble, something that means fatal, something that means embarrassing. I thank God for Dr. Hummel and Jan, who shared these great points with us, but we need to work in removing that stigma. So what we want to do is allow them to breathe again and be available for them as their support. So A, assess. B, breathe. C, we want to allow them to collect data. First of all, what is the diagnosis? What does this diagnosis mean? People hear the word, but they may not know exactly what dementia is. So allow them to collect data, but most importantly, also find out where are the support groups that are going to be able to be available and accessible for you and your family. So A, assess. B, breathe. C, collect data. And when they connect with these support groups, I found it awesome, even there at the UT Health Science Center, that the more people you talk to, the more pictures that are painted, the more examples that are given, the more experiences that are dialogued, the more testimonies you hear. And then all of a sudden you don't feel as much overload. You start getting more understanding. If you don't mind, I'm going to go to my next point, if you will, identifying barriers that might prevent people living with dementia and their families from seeking what they need. Now, we know that there can be financial barriers, there can be geographical barriers, there's all type of barriers, but I would like to focus on the barriers such as emotional and social just for a moment. From the emotional side, intimidation. Number one, people fear the unknown, or they fear what they don't know, or they fear what they don't understand. So now they're facing what they're fearing, and they don't know how to take this on because this never happened in my family. No one in this family has this diagnosis. So now they go from being a family with pride to a family with a problem. So now we got to get rid of that barrier that's intimidating. Secondly, Jan spoke on this, and Reverend Hummel spoke on this, the stigma. We have to be able to battle this stigma and overcome the stigma. Let me just say it like this: hearsay versus the facts. When your family member receives this diagnosis, remember, he or she is still your parent, they're still your spouse, they're still your hero, they're still your grandparent, they're still your godparent, and do not let the diagnosis strip them of that title. Don't allow a stigma to interfere with the existing relationship that's going on, because you don't shift from a proud family to a problem family. You continue to move on as a proud family to a victorious family, because we're going to overcome this thing together. And one of the worst things you could ever do is move from a family of dreamers to now living a dreary life. That's not so. Reverend painted this out very clearly. We don't go from living one way to another. What we do is we perform with it, and we also succeed with it. Another point I want to share with you, typecasting. I found this out in my own research: color, culture, and kind. Now, typecasting is an issue. Color, culture, and kind. Some people feel, well, our people don't get this, and they're very wrong because they don't know the facts, or our color don't get this, or our kind does not get this. And that's not true whatsoever. Anybody can get it, but if anybody can get it, everybody can overcome it. As long as we're in this thing together, we have to have that mindset of overcoming these barriers. No person has to deal with this alone. Everybody needs somebody, whether they want to admit it or not. One of the last points I just want to share with you all: how to ensure that people living with dementia and their families in rural areas have the resources that they need. Let me share this with you. Meet your new kinfolk. Just because they're on the outskirts doesn't mean that they're outcast. Meet your new kinfolk. We're family. So that means that we either have to go out there physically or electronically to meet them, but we must be consistent about the information we're sharing. And I believe that it was mentioned earlier, no one wants to feel excluded. We all have to be included if this is a family deal. Again, include the excluded. Just because a person, they're not part of the general population, doesn't mean that they don't serve an important purpose. And we need to watch how we say things. We need to speak we and not you all, or as in Texas, we would say y'all. We need to speak we, inclusiveness. Last but not least, we need to be accessible and be available by all avenues. Face-to-face, which we call FaceTime, telephone, which we say cell phone, letter, which we say email, and be consistent with your caring character. Thank you all.
Wow, amazing, James. Thank you so much. I want to invite our panelists to all activate their cameras. I think, can y'all see us again? Okay, so I think Ginny had to hop off the call for an event at the Alzheimer's Association, but I wanted to read out a few questions that came through. And I just wanted to thank you again one more time, just absolutely wonderful presentations. So this first question is specifically for Kiki and Michael, and it's a question from Donna Futrell, and she asks, do Kiki and Michael, oops, that's the alarm. Do Kiki and Michael participate in support groups for people living with Lewy body dementia? Oh, can you unmute?
Thank you for the question, Donna. No, at this point, we do not. We're looking for one that we can get involved with in the San Antonio area. But now with COVID, you know, we're willing to go virtual. So if you have any leads on that, pass them along. We would appreciate them.
It all started with a bottle of wine.
That is an amazing story. And Michael, if you're comfortable, we'd love to share it with the attendees today.
Absolutely.
Thank you so much. So Sherry Ramstead has a message, for not so much a question, but says, amen, James, all great points. And I'm not just saying that because I'm your intern. Thank you. So I have a couple of questions. I don't know, Carol, also if you might have some, but I would like to ask the panelists something that has come up several times when discussing this project with our community. It's about engaging with people who are not at the table, so to speak. So what is some advice that you can lend to researchers working with communities to reach the people who might not already be connected to these research opportunities?
That's a rough one. That's a rough one. The only thing that I can say, because we find that here in our own community that we live in now, is just keep talking. Just keep talking. And so many times people think that what they have to offer isn't worthwhile, or it's just so little it won't make any difference. And especially with research, that little nugget can be what the gold digger was looking for.
Thank you. Do any of our other panelists, Angelica or James, want to comment on that question?
Yeah, I mean, I think that's really important. And it really is going to, from a clinician or researcher side, I mean, you really have to sit there and say, who are we missing, right? Who have we not heard from? And then seek them out. And obviously, you know, that's effort and time and things like that, but we miss people, you know, if we don't seek them out. And so that's an important, it's really important to identify those that we're not hearing from.
Thank you so much.
And Sarah, may I just add to this, I think we have to be particularly cognizant of it with not having in-person events. So what are ways that people who might not be able to get on Zoom like everyone is here today, what are other ways and what are other ways, formats that they communicate in, whether it's WhatsApp or Facebook, what other things can we be doing?
Door to door still works. It doesn't mean I'm coming inside your house, but it still works. We can make it personal wherever possible. There are so many opportunities in different neighborhoods. People are drawn to individuals that give them attention, that are consistent, that have integrity, and that are sincere. Sometimes you can't see that online, and you can't see that through an email, but if you make an appearance, that makes an impact. And then also, we can't approach this as if it's a market. We have to approach it for what it is. It's a life. It's a relationship. And people can tell when you really love or compassionate or passionate about what you do. They're drawn to that. Like looking at this lovely couple, Mike and Kiki right now, they're drawn to each other.
Yeah.
That's wonderful. Well said. Thank you so much. And there's some comments coming through saying that is so true. Okay, so I want to read a comment from Myra, who's another member of the Advisory Council, confirming that authentic connections are necessary indeed. And I do want to comment that there are some Lewy body support groups that will share the information with you all.
Thank you.
From Angela with the Biggs Institute. So before I ask my next question, I wanted to invite Carol. Do you have anything that you'd like to ask the panelists?
Not right now, but actually I was wondering if we wanted to bring the other speakers on, because there are, or is that where you were going to go? But there's a couple of questions that were sent in by email that probably we could address more generally.
Yes, please. That's a great idea. And there was one question submitted through the Q&A after Jan's presentation that we didn't have the time to get to also. Should I ask that now? Is that okay? So Jan, one of our attendees asks, how do you keep the dignity of the dying person who is angry about physical losses, such as falling, calling the fire department, for lift assists, or needing to be fed, needing support with feeding? And I'd like to invite any of the panelists to add on to this question as well.
So I want to follow up, I guess, and use some of Kiki's comments, if I might. So I think having open and honest discussions where it's possible is really important. And yet, even for people maybe who lack insight with this illness, you know, one is I would acknowledge the emotion, you know, that they're angry. They should be angry, right? This is not good. It's not fair. And I think oftentimes we try to candy coat things or ignore things. So I think the most dignified thing I would do is just, first of all, acknowledge the loss, to say, I know you're angry. I would agree. You have every right to be angry. And then say, I'm here to help. Right. So if our emotions are ignored, which are the strongest things, right, within, if you look at this bookcase analogy, that our emotional memory is at the very bottom of the shelf, and our memory for short-term events are on the top, and when dementia rocks the bookshelf, the book on the top falls off. But the books on the bottom, the emotional self stays intact despite the progression of the illness. So acknowledging emotion and the person is absolutely imperative in this. And then, you know, certainly, yeah, we're going to have to call the fire department for assistance. But what's important then as a partner is to share to the members of the fire team, this is what you need to know about this person. Please acknowledge, talk to him. Don't talk to me. You know, look at him.
Exactly.
Acknowledge him, acknowledge her, because that just feeds the frustration and the anger. But I think acknowledging the loss that this person is feeling and being open about that is critical, and having a trusting relationship.
I agree. Pre-COVID, when people would come up to me and ask, how is Michael doing? I said, I don't know. He looks fine to me. Why don't you talk to him?
One thing I've always found, and what I try and do 90% of the time, is see if I can't get the person to laugh or smile. If I can make some humor out of this thing and get everybody giggling, I found it's a lot easier to work with. And sometimes you have to do something stupid yourself, so get them laughing at you, but that's fine with me. I don't mind being laughed at.
Laughed with. We definitely, there's a lot of smiling faces whenever Mike walks in a room or logs into a room. Do any of the other panelists want to share on that?
I completely agree with everything Ms. Jan was saying. I also try to get my patients to focus on the positives, right? If we focus on the negatives, there can be many things that we end up focusing on. So yes, the negatives are there, and we will work to make those better and continue to try to improve those. But let's focus on the positives and make sure that we're still keeping those shines of light in our life.
I agree with everyone. Oh, sorry. I was going to say, I agree with everyone that has spoken. It's really important that individuals do not feel alone. It's really important that they do not feel alone. Because many people can feel like they're out in a shallow end and they're by themselves, but it's very important that the individual does not feel alone and that they have a tangible support and a positive support like Dr. Davila mentioned. I do agree with everything.
I'd like to speak to that, Sarah, that, but many of us do live alone. That's the reality. I think the statistics I read were over 30% of people are living alone, and many of us have dementia. And so helping people to build their networks of support. You may not have a close relative nearby, but you may be able to build a network of support through associations from church or synagogue or from other activities that you're involved with, to have that that plan in place, those circles of support, people that you can call on.
They're critical.
Thank you.
Very much so. And a birdie just whispered in my ear, pun intended, outside, focus on life and not the diagnosis.
There you go.
Thank you so much, Birdie.
Thank you. Okay, yes, thank you. And that does speak a lot to, you know, Jan's priorities around socialization and living well with dementia, and what Kiki had mentioned with, you know, coming up with a plan as early as possible. So I think that's all absolutely in line. There was a question submitted through the Q&A for Dr. Davila. Does one make an appointment to see a clinician like yourself? And I think if you'd like to answer that, also just sort of, we did come across in working with the advisory panel a lot of questions about, you know, where you get your diagnosis initially. How do people sort of navigate that? That would be helpful.
Sure. Yes, so we here at UT Geriatrics, we do, because we are primary care as well, we are consultants as well. You can call and make an appointment to either do a primary care visit or actually just get a consultation for the diagnosis. But in general, so if we back up, your general practitioner, whether family medicine, internal medicine, they are your first go-to, right? You should be expressing your concerns with them. Again, some people are very well-versed in it, some people are not. And so I'm hoping that they will at least try to guide you to the next step. The next step may be a geriatrician, where, you know, we who take care of older adults are pretty well versed in this area. They may also send you to a neurologist. That would be their choice if they want to go that route as well. And the neurologists obviously do this all day long as well. So just kind of depending on what you're looking for. If you're really looking for a new home for someone to take care of you, that would be maybe a geriatrician that could continue to service you as a primary care. Or if you're looking just for a diagnosis, the geriatricians or neurologists could help with giving a diagnosis.
Thank you.
Thank you.
Thank you. Carol, do you have a specific question before I go through the rest on the list? There are more comments, really.
I was going to ask, particularly Jan and Cynthia, maybe just for a few comments on how we move forward in our city. We have dementia-friendly San Antonio designation, and there were a number of questions or topics in the topics that we're prioritizing that relate to stigma and dementia-friendly. So just from both of your experiences, and Cynthia, why don't you go for first? What are things that we can continue to do at a community level to support people?
I think at a community level, the training and it should be ongoing. Introducing or offering opportunities for the different stakeholders in the community to understand what dementia is and how different people experience dementia, but to have those opportunities. Now we can do it in a virtual way, to be able to reach out to our community servers, the fire, the police, the EMTs, those folks, bank tellers. They might be the first people who would notice a change in cognitive abilities. To be able to speak even virtually to faith communities, church groups, synagogues, mosques, to be able to have different opportunities at different times of day, with maybe different topics, so that people can learn. I was thinking about restaurant personnel. When people are are dining out, if you're dining with somebody who's perhaps having more difficulty because of his or her dementia, being able to train, have a seminar available for people who are in food service or who are meeting people who just don't know, it's not been part of their experience. So they want to know what to do or how to react. So I think there's lots of opportunities, especially now virtually.
Yeah. So awareness and then education so that we have action.
Yep.
Thank you. Jan, do you want to add to that?
I think that's the first thing, is just to build awareness and then understanding, giving people tools on how to act. So one of the things we did with our Dementia Friendly Tempe is that we trained all of our first responders, police and fire, and scenarios, and that was really helpful, because I think the awkwardness that comes is I've never encountered this, I don't want to say the wrong thing, I'm afraid of doing the wrong thing, and so I think it really builds on that. And I agree with Cynthia, as we look at these various sectors, one area that I think is very important is a faith community. And how does a faith community begin? What does dementia friendly look like in that environment? Again, how do we design worship where people feel still welcome? I grew up traditionally where it was all the old people that went to the 8:30 service, but when you're living with dementia, 8:30 isn't a good time to be having to attend a service. So how do we begin to make accommodations? And then I would comment, in our senior communities, which we're seeing, explosion, at least in Arizona, senior communities everywhere. There is so much stigma and there is so much individuals living with dementia on those campuses that must stop. But again, it begins with building awareness and understanding and compassion and dignity and providing those opportunities. We've got a lot of work to do before we're truly dementia friendly. Long ways to go. But all things and times. I'm really struck through my travel work actually about the work that's been done in the autism community to support their individuals to travel and their families. But when I talk about Alzheimer's in the travel community, oh, you wouldn't believe the stigma that rises. And I think, well, it's interesting because often many of the strategies or supports would look very similar for the person with autism as it would for the person who is living with dementia. We need to keep pushing and building awareness in a respectful way. Again, that builds upon the ability and possibilities for these folks rather than making assumptions that we have people who are completely incapable.
Rachel, this brings up, I think, a comment that I just wanted to make, and then I'm going to turn it over to Sarah, and you can maybe comment on it. But you talked about the dementia and the caregiving portfolios from PCORI, and that they're focused a lot on education of healthcare providers, and we could think about the community. So I think we've heard well today what kind of outcomes matter to people, and so I think it lends itself to one of those topics that have been rising in when we've been prioritizing, that having communities that are inclusive are outcomes that matter to people. So stay tuned for an application from us.
Great.
Yeah. Sarah, I'll let you just finish with the last comments, and then I'll just make a couple of comments as well. Thank you.
Yeah, absolutely. Rachel, I saw you unmuted. Did you want to say one thing real quick about that?
Oh no, this has been so incredible, and I'm so glad I was able to be a part of this and to learn from you all. So I'm looking forward to your continued work.
Thank you, Rachel, and we're lucky to have learned from you earlier today too. There's only one more, it's more of a comment, and it's from somebody we've connected recently through our Caring for the Caregiver program on behalf of Team Maria. So Tech shares, I am looking for virtual social events in Spanish for my mom, a former corporate gal, a non-agenarian with early to mid-stage vascular dementia. We love being new members of the SA Amigos Memory Cafe. Tech's mom was very social and loves conversation. So Jan, this speaks to the socialization, especially in times of COVID, like we've been discussing, and listens to international radio in Spanish. But that doesn't replace conversation. So I wanted to read this comment out loud in the last 5 minutes, more to just sort of bring awareness to all the attendees, but to invite any of the speakers to discuss the importance of socialization, but also that more cultural language inclusivity that has become so, the need has become so much more apparent since we've gone virtual. Do any of the speakers want to comment on that?
Yeah, so we've actually been searching high and low to make sure we can provide something for our patients. We have a lot of patients who miss that socialization. COVID has unfortunately taken a huge impact on our patients. The isolation
Thank you, Mr. President.
the isolation has just been horrible for our patients. Now, the one resource we have found, Catholic Charities does have a volunteer program. I can't remember, I think it's called like Senior Buddy, but they do have people who are willing to call and converse with families or patients just to kind of give them a little bit of companionship. I have encouraged my families to call the local senior centers. I have heard that the senior centers are still checking in with the people who used to go to their senior center. So obviously if they have any kind of program, if they know of someone who really could use some, a buddy to talk to, we're still encouraging that. A lot of my patients are still going and doing things. So obviously I've encouraged families to really focus on their loved one, the things that they still may be able to do, and how can you connect. Some are still going to the gym and doing water therapy, of course, 6 feet apart with masks, things like that. So, things are starting to just open up a little bit. Obviously it'll be the family's comfort level of trying to get them out, but local senior centers, Catholic Charities, maybe to see if there's some virtual or on the phone program.
Thank you so much.
I just make one comment that one thing that, as I work with care partners, that I think is a really important skill to learn is to ask for and accept help. So being very specific about what your needs are, because I think, unfortunately, one of the things that our culture brings in America is a sense of independence. I could do it myself. We hear it from the time you're 3, but there's a point at which you can't really, we need to be interdependent as a nation, and particularly in this condition. So how is it we reach out to people in our network to ask them to call and what is it they could do, even through frequent calls, right? Because I hear someone who's longing to just stay connected to the people who make her feel loved and important. And isn't that what we all want? And so sometimes I think we overthink it and think about just what could be the simple things that we could ask for somebody to do that could take 15 minutes during their day and simply put a call. So if you get 3 people calling at different times of the day, that even makes it. The other thing, I was just on a webinar with a geriatrician from UCSF. I love geriatricians. They're just brilliant people. And she had the best thing was, why don't we give older adults N95 masks and allow them to get out, right? So we need, from a policy perspective, to start thinking about, because we're not protecting our elders, we're killing them because of isolation. And I feel very strongly about this, that we have got to think more proactively about how do we let these adults make decisions that are right for them and give them the protective gear that they need that allows them to stay connected to the people they love. It's a tragedy right now.
So I'm going to jump in here to keep us on time for the day. So I want to thank our wonderful speakers and our panelists for giving up your morning to inspire us. I think to also, I think we've had so much relevant practical information. And then I think hope. I think you've given us all hope. And I think it's crucial because I think hearing the voices of our stakeholders about what's important to them, we didn't used to hear that 10 years ago. So I think that gives us hope in knowing what matters to you and how can we move forward. So you've seen a little spattering of our questions. We had about 95 to 100 topics that people had generated from their networks that were important for them for research. Dr. Davila helped us to reduce that list, and we now have 46 topics that are important. If you haven't yet helped us to prioritize that, you're going to get a link. If you've already seen it, you can get rid of it. But we really are wanting to hear from everyone, from people living with dementia, from their care partners, and from our other stakeholders about what is the multi-perspective on what's important to people. So you will receive that. You'll also receive another link just to give us some feedback. It's sort of a pulse check, we're calling it now. That's from PCORI. I like that term, sort of an evaluation. But we will have more seminars in the future and symposiums. So tell us what you want to hear. We want to know what's important to you. So thank you all, and for attending, for spending your morning with us as well. We're really grateful. Thank you.
Thanks for everything.
Thank you.
Thank you. Bye.
Bye.
Bye-bye.